And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Hello, everyone. Welcome to another episode of the Research Works podcast. I do have a question to start off with. Ash?
I ask the questions.
I know. I figured today I might, change it up. It's been really cold, as you can hear us talk about lately, and it sounds like I'm whinging, and I probably am. But I was curious, how's all that PJ tucking going?
It's going really well, thanks, Dana. Everything is tucked in. My singlet under my pajamas, my socks into my pajama pants.
So fabulous.
My pajama pants into my slippers. It's all multifaceted tucking. Thank you for asking.
You have inspired me, and every time I get into my PJs, I make sure everything's tucked and I think about you. So look at that influence you've had on me.
I'm pleased to hear it.
Well, on the pod this week, we're not just talking about our PJs and our tucking habits. We do have the ever so fabulous Dr. Magnus Påhlman from Gothenburg, Sweden, joining us. And some of you guys might remember that we spoke to Magnus last year in brief when we're sort of doing a combination with Kate Langdon about ADHD, ASD, and the co-occurrence and cerebral palsy. But this time we've got a full pod with Magnus. Hello, Magnus, and welcome.
Hello, thank you very much. Feel very honored to be here again.
Oh, that's so great.
We feel honored that you decided to come back. So thank you for talking to us again. And the paper we're going to be talking about with Magnus today was published in Developmental Medicine and Child Neurology this year, 2022, and is titled Neuroimaging Findings in Children with Cerebral Palsy with Autism and or Attention Deficit Hyperactivity Disorder, a population-based study. But before we get into that, we're going to tell you a little bit about Magnus. Magnus is a paediatric neurologist working with children with cerebral palsy at the Regional Rehabilitation Centre at Queen Sylvia Children's Hospital in Gothenburg. Magnus is also a researcher at the Gillberg Neuropsychiatry Centre Institute of Neuroscience and Physiology and the University of Gothenburg in Sweden. Magnus completed his PhD back in 2020, and his dissertation was to increase knowledge about the prevalence of ADHD and ASD by studying neuropsychiatric disabilities in a group of children with CP in Western Sweden. Magnus was driven to do his PhD as he realised there was a significant gap both in the literature and in clinical practice, and he was determined to increase our knowledge so that with the right help and support, we can provide that to children and their families.
Oh, and that's just so true. Even after the last time we spoke and once we understood the prevalence, I've been able to talk to families about that. We've been able to communicate it, and so many people have just, really just appreciate that information. So this is just the next step, isn't it, Magnus? So thank you so much for doing this work and being able to talk us through all of the findings.
It was a good summary of you made.
Ash is really good at reading these summaries. Like I make sure that she does these because she's really good at pronouncing words. She's far better than I am. And you do a really good job.
I'm sure it will come unstuck sooner rather than later. But thank you, Magnus. So before we get started diving into the details of this paper, we like to start our episodes with a bit of an icebreaker question. And the question I thought we would ask and talk about today is, what game makes you the most competitive?
Oh.
Dana, are you competitive?
I am competitive, but I pretend that I'm not that competitive because of what it does to me. It destroys me, and I pretend it's all about just being part of something, but I really want to win.
Yes.
So I think that's part of it. Look, I would say the game that makes me most competitive isn't me actually doing any of it. It's actually watching it. So I love tennis and I love Rafael Nadal. Like, I think he's great. but I get really emotional watching them play. Sometimes they're really close, and I feel like every time I watch, like I might not help him, so I'll turn it off so I don't watch it, so I'm not so emotional. But then I'll get my phone out and I'll look at the sort of results as they're coming along, and I'll hear about it, or I'll jump around and move away. It's like an emotional wreck. And these five setters,
you're invested.
It's a long time.
Yes.
Yeah, it's not good for me. So watching it is when my competitiveness comes out. Curious, Magnus, what about you?
Well, I recognize your thoughts. I love football and especially following Liverpool Football Club in England. So, but I feel I'm a bit too engaged in it. So
you're also invested.
I recognize just turning the match off and follow the results.
Yes. Sometimes it's a bit much.
It's not good feeling too bad about sport, but it does.
And a challenging year for you this year to be a Liverpool supporter. They've got close quite a few times, didn't they?
Yeah.
Oh, Ash.
But they also
cool.
But they also won twice.
Yes. You've got to take the success where you can get it.
You do indeed. I'm curious where this question came from. So tell me.
Well, I was actually inspired by the Swedish flavour of our podcast today.
Fabulous.
And
cool.
I thought about a game that a friend of mine introduced to our group of friends because he is Swedish. And Magnus, I know I'm going to butcher the pronunciation of this particular game. Kubb, I think. Is that right? Yeah. So this game, Kubb, it's a bit like a stand-up game of chess is the best way I can describe it, but it's not really that. There's lots of throwing of like wooden pegs to knock over other wooden pegs, and you work in teams, and so there is a competitive element to it. So it brings out, I don't want to say it brings out the worst in me, but it brings out my competitive side.
Are you very selective of who's on your team?
Absolutely.
I mean, that starts
Absolutely.
Right.
You have to be strategic about these kinds of things.
Okay.
Yeah.
So it doesn't matter if you're good friends, husband, doesn't matter. You just want to win.
You leave all that on the sidelines. Yeah.
That's probably competitive. Well, it seems like we're all a little bit competitive. So that's a little bit more that you guys know about us. I'm sure that's what you guys wanted to know. Okay, so given the co-occurrence of ASD, ADHD, and intellectual disability in children with cerebral palsy, the authors of this paper aim to describe and compare neuroimaging patterns in a population-based group of children with cerebral palsy in relation to the presences of ASD, ADHD, and relate these findings to gestational age, CP, and intellectual disability. So neuroimaging was reviewed in children with cerebral palsy who had completed neuroimaging, as well as having completed a comprehensive screening and clinical assessment for ASD and ADHD. So included in the study were 184 children, which represented 70% of the total population of children with CP and 92% of the children that were also assessed for ASD and ADHD that were born between 1999 and 2006. And this was all from a well-established CP register in Western Sweden. The results indicate that although ASD and ADHD were common regardless of neuroimaging patterns, the timing and localization of insult appear to be of importance for the occurrence of ASD and ADHD. And ASD was more often associated with white matter injury and ADHD with middle cerebral artery infarction.
Thanks for that summary, Dana. I think you threw yourself a few big words in there as well.
I know. There was a few curls there, but I got through it.
You got through it. So, Magnus, we know that cerebral palsy is a group of motor disorders attributed to non-progressive disturbances in the developing brain. And because of this, neuroimaging forms a really important part of both diagnosing and understanding the disorder. So I thought you could perhaps start by telling us a little bit about how we use MRIs in diagnosis.
Yeah, of course, cerebral palsy is a clinical diagnosis, so MRI is not mandatory for the diagnosis. And of course, in several parts of the world, the MRI is not accessible, so it's not, you do not have to do it, but it will really help you in diagnosing, be more sure, understand more about the pathology behind. I think that is one part that is important for families to more understand why my child has cerebral palsy. And it gives you more information than that. And my paper is one of more knowledge being published the last year that the neuroimaging findings can be associated with other impairments and give you more information than just the background.
Of course. And when you're so the classification system that you use for looking at MRI, in brief, what does that kind of tell us about the injury and about the brain?
We use the MRICS, that is the MRI classification system.
Okay.
It was developed by the Surveillance of Cerebral Palsy in Europe for the use in registers.
Sure.
So it is built on the timing of the insult to identify the pathological pattern related to cerebral palsy. And it's also made to be easy to use, because in registers it should be used in similar ways and could be used both by neurologists and epidemiologists. And it's a tool more about the quantitative lesions than topography or degree of the lesion.
Yeah. I just feel like that's where everything's headed in terms of like a classification system to really just help to communicate and be able to describe, and it just gives you a good snapshot, I suppose, of I mean, an MRI really is read by someone as skilled as someone like you, as a neurologist. So for you to be able to communicate that in a way to someone who doesn't need to know that detail of what you can see, but for you to be able to communicate that, I think makes a whole lot of sense.
And it has been very useful and it's been validated, and it works well, the MRICS classification.
Yeah, that's really good.
So with that classification, do you get information from that about, I suppose, the type of injury that there is, but also when that injury might have occurred?
Yes, the development, it's in the definition of CP that it's the immature brain having a lesion of some type or disturbance. And the classification is therefore built on the timing because different areas are sensible for different reasons during the development. And it's what is used as the base in the classification.
And I'm really interested in the paper you do sort of describe that, you have an abnormality in MRI in nearly 90% of children with cerebral palsy, which does mean in 10% you may not find any abnormality in the MRI. Can you just talk us through that part of it? Because I think that's something that, parents often are sitting and waiting sometimes for their MRI to find out what's going on, though they might show clinical signs of CP, yet they go and have the MRI and they're like, oh, there's nothing to really report. Can you just talk us through what the possibilities of what that might mean and how we can talk to families about that?
Well, the MRI is a very high resolution investigation compared to what we used before, more than the computed tomography, that when you can't see everything for sure. Maybe there are things not visible on the MRI as well, but I think it's more about function and structure. You often just visualize the structure on a usual MRI.
Sure.
But it's more about the function. There are always things you can't see actually.
Yeah. Okay. Yeah, and it's
but
good
you
to
should
know that.
also be aware of the normal MRI, that you might have to think more about the origin.
Yes.
There are more and more reasons to look for genetic background in some cases, and that might be a flag for thinking about it at least.
Yeah. No, that's a really good point. I feel like that's something that comes up quite frequently when you particularly in the early intervention space, and people are obviously really thinking about MRIs at that particular time. Now, I just wanted to ask a few questions with regards to the sort of the terminology of neuropsychiatric disorders. And obviously in a previous paper when we spoke about that, we talked about ASD and ADHD. So can you just talk a little bit about broadly, what is a neuropsychiatric disorder?
That's a hard question because the neuropsychiatry word is used slightly different, I think, in different settings.
Okay.
We use it mainly for autism, ADHD, and other symptoms like tics, Tourette syndrome, of sometimes anorexia is in the neuropsychiatric area, but you have the term neurodevelopmental as well, which is used in the DSM-5 manual, and they are close, they are related. So it's hard to really define what is neuropsychiatry.
Sure.
But for me and in Sweden we use it mainly for those disorders that I have studied.
Yeah, sure.
So when we talk about autism spectrum disorder, attention deficit hyperactivity disorder, and intellectual disability, could you just remind us again about their co-occurrence with cerebral palsy?
Yeah. That was my main goal in my project.
Yeah.
We found both autism and ADHD being more common than we had expected and what was described earlier. Autism and or ADHD was present in nearly half of the children. It was 45%. And 30% had autism and 30% had ADHD, but there was quite a huge overlap between those diagnoses. And they were connected mainly with intellectual disability, not with the severity of the motor impairment. And that was, to us, surprising because other impairments are very much connected to the severity of the motor symptoms.
Yeah, I remember when we talked about those results, it was surprising. Like, it was surprising to see the numbers so high. And then when you really start to think about some of the children that you might be working with, and you start thinking about all the strategies that you put in place, sometimes you intuitively put in strategies without necessarily a diagnosis, but you're already thinking about how you can manage, certain preferences and behaviors. And it was really something that has changed how I practice. So, really cool.
I was just thinking that you're often probably responding to the behaviors that you're seeing. You're not necessarily putting a label on them as such, but you're having to respond to those behaviors in a way that's consistent with what you might expect from.
And this just helped to understand it, it was so great, which is why this paper is so interesting.
And of course that was the purpose, to better understand the children, to help them in a better or different way than because all children with cerebral palsy have their own mixture of motor symptoms, other neurological symptoms, associated impairments. We talk about different functional profiles for each child. And it is fair for the child to be understood in the right way.
No, absolutely right.
So who was included in the population for this study, Magnus?
Well, it's a chain of studies. We started with a population-based group. That was 264 children. And that was all children with cerebral palsy in Western Sweden, born 1999 to 2006. And through our studies to find out the prevalence of autism and ADHD, there was, of course, some dropouts, but we had 200 children who was investigated. And then from those 200 children, we looked who had undergone neuroimaging.
Yep.
And we found 192 having done that, mostly MRI and some CT as well. Just 8 children had no neuroimaging done.
Yeah.
That's a pretty comprehensive number, like with
it really
with that.
is.
Yeah.
Yeah, and I can see why. I mean, we've talked about the strength of the Western Sweden Cerebral Palsy Register. I remember last time when we had Kate Langdon here, she was pretty much salivating over how amazing that register is. It's the oldest, it's very comprehensive. So it's, there's great strength in population-based studies, aren't they, Magnus?
Yes, and that register is a gold mine for studies of different aspects of CP as well.
Yeah. Just laying that foundation so early on, and to be able to, then start collecting data and the right kind of data that, as our knowledge becomes better, you'll be able to draw back on that. One of the things I did want to ask you about the actual registers is that you did want to sort of look at the gestational age in the relationship with the neuroimaging findings as well. I thought before we get into any of the results, can you just talk to us and summarize, I guess, the different sort of gestational ages they are and what they include?
It's easier to talk about several weeks than just single weeks, because it's not that exact. And we use the term extremely preterm when you're born before 28 weeks of gestation. And then we have the very preterm 28 to 31 weeks, and the moderate preterm in 32 to 36, and then the term born from 36 weeks on, 37 weeks on.
Yep. So now to the really exciting and the juicy stuff of what you found. And I'm really looking forward to hearing you explain this through to us, because I'm so intrigued by it. So I guess, can you talk us through some of the neuroimaging patterns that you found? Very broad question, but I'll let you just go for it, and I'll just fire away lots of questions as you go along pretty much. Take it away, Magnus.
Well, autism and ADHD were common regardless of the neuroimaging pattern you found. Even in the group with the normal MRI, autism and ADHD were common and not significantly lower than in the other groups. So in a way, brain disturbance per se seemed to increase the prevalence or the likability of having autism and ADHD as well.
Wow. Okay.
It's really interesting.
We found two lesions more related to diagnosis, but the main finding was it's common regardless of neuroimaging finding. But it in a while, or in the same time, it was similar for me then, that we found autism and ADHD being common regardless of degree of motor impairment. We found autism and ADHD common regardless of neuroimaging finding. Some sort of connection there for me. But autism was more common in children with predominant white matter injury.
Yeah, can you talk me through that? Obviously, can you let's go back to white matter injury and what that might clinically look like. Maybe can we start there? I would love to hear you talk about what that means.
White matter injury is the most common neuroimaging finding in cerebral palsy. And it's the white matter injury is said to occur in the premature brain, often in the more common in the preterm than the children born term. So it's the typical lesion of preterm born children. You have the white matter injury. You often have spastic diplegia or bilateral spastic CP. You often have some problems with vision, perception as well.
Yep. So we're really talking about that GMFCS level. Like, what sort of GMFCS levels would you most likely see someone with a white matter injury? Like, I think you sort of kind of described it there, but what sort of motor functioning might this person have?
It could be actually any GMFCS level, but it's more common with lower levels, GMFCS 1, 2, 3. But there are 4 or 5 as well.
Yeah.
And when we talk about a white matter injury, is that are we looking at any particular from a function perspective? Are there any particular areas of the brain that are affected and then therefore might lead to these symptoms of autism spectrum or ADHD more so?
It's quite a hard question. Because white matter injuries, you can see changes in the corpus callosum, the cerebellum, as well as the periventricular white matter. And it's a question of, do these changes themselves predict the autism, or are there other changes or affecting networks at the same time, making these children more likely having autism? That we don't know.
Yeah. It's interesting, I guess, when you look at the functioning. You mentioned there before about, visual perception, difficulties, and, I think that's why it's just so important to get a good clinical history and a good examination and assessment, because if you're seeing these things and you're saying that, particularly if they're preterm, you might be thinking in the back of your mind already as you're meeting a new client, a new child, and you get in the history, they may not have the diagnosis of ASD yet, but you have that in the back of your mind potentially of, if you're noticing things, how you can talk to families about it and where that might go. So it's a really interesting finding. And I think that there's a lot of practicalities there in terms of the strategies. I mentioned before about, how you start to put strategies in place, and sometimes you do it intuitively as a clinician, because you know that certain children might need certain support. But now we've got a bit more language to it to kind
more
of
of a
go,
picture.
Yeah. So that's really, really interesting. So that was one of the really specific findings, was that with regards to the white matter injury. Now you had another one that was very quite specific as well. Can you talk us through that one?
That was even more specific. That was the children having middle cerebral artery infarction very often had ADHD. It was nearly 2/3 of those children having ADHD.
And for our listeners who might not be familiar with the terminology, what does middle cerebral artery infarction mean?
Well, it's one of the main arteries supplying the brain with blood, and it's the most common infarction problems with the circulation appearing in small children. It is mainly occurring more in term age, around the time when the children are born, late in the pregnancy, or it might appear in the neonatal period as well.
Okay, so it's so with the white matter injuries, you see that more in the preterm infants, but this infarction generally occurs kind of later on, so either kind of quite late in gestation or even sometimes after the baby is born, if they're born at term. Is that right?
Yes, it might be. You don't often use the word stroke in very small children, but when they are older, they can have a stroke, and it could be a middle cerebral artery infarction.
Sure. And that was my next question for you. So I suppose, you tend to see more unilateral presentation. Is that correct?
Yeah.
Yep.
Yes, it is.
Wow.
They are almost all of them are unilateral, spastic.
Yep.
Yeah.
Again, very interesting, because I'm already thinking about, the children that you might be seeing that present with the, more likely your GMS is level 1 and 2 potentially. Mm-hmm. So mobile, and it's just interesting to note that, if they're more likely to have ADHD, then there'll be some strategies you can put into place really early on to sort of support children in their learning, I suppose. Mm-hmm. Do you have any theories, I suppose, of why you think the two are linked? Why would a middle cerebral artery infarction be related to ADHD? I mean,
that was my question too.
Was it? Sorry, I'm very curious.
Me too. We're both very curious about it.
Well, I could hope I had a good theory, but I think there's something in the imbalance in the brain. I was looking whether a left side infarction or a right side infarction made any difference, but we couldn't see that.
Right.
And I read other articles describing stroke in small children, saying the same thing, that attention problems are common after a stroke.
Also, even later in childhood, if they were to have a stroke.
Yes.
Right.
Yeah.
Oh, that's very interesting.
Yes, it is. So there is something there in the imbalance, but I'm not a neurophysiologist being able to explain theories, but there are more data coming about that. But actually here we have also one of the reasons that neuroimaging can really make a difference, because when you have a child with a unilateral spastic CP, the most common finding are a middle cerebral artery infarction or white matter injury on one side as well. But you could see that the children having had an infarction more often had other impairments. It's not only this study, but I had one of the studies from Darcy Feelings and collaborators also highlighted that children with having infarction often had more associated impairments than the children with a white matter injury. So there you could have a direct advantage of having an MRI done to see the background of the lesion.
Yeah. So to advocate for that would be important. And I'm reminded when you say this, we've had Dr. Jane Valentine on the show before as well. And I work very closely with Jane often. And she would always ask me, Dana, what's the etiology? It's cerebral palsy isn't a diagnosis. We want to know if it's HIE, is it middle cerebral artery? Is it, is it PVL? And really getting to that detail. And even as a clinician working in the community, and you get in a medical history, it's really worthwhile. I mean, I think this is how I've been trained by Jane, is to go, what is the etiology? Understand that part of it. And now that you link all of this together, you can now piece all of that together. Which is really, really cool.
Yeah, it's I think it's important to link function, etiology, function and structure to better understand and hopefully do a better clinical job with the children.
Yes. I wanted to ask you a bit about basal ganglia and potentially how they might play into some of the behaviours that we see in children with autism spectrum disorder. Could you just explain how basal ganglia tie into all of the other complex things we've been talking about with regards to brain injury site and the behaviours that we kind of see as a result of that?
Yeah, well, we found in our previous study that children with dyskinetic CP, often the ones having basal ganglia lesions,
that's right, yep,
had an obvious restrictive behavior pattern of activities, and so even if they didn't have autism fully filled the criteria. And there is something there in the basal ganglia affecting how you function. I found some other article describing just that connection between the basal ganglia lesions and restrictive behavior. And so there are also something there that needs to be described better and understand in a better way.
Yeah. And it's interesting, isn't it? Because, when we talk about basal ganglia lesions, some typical movements will be these really repetitious, really stereotyped movements. And I guess, there's often those descriptions that families might describe for their children with autism and say, there are these repetitious movements and how's that associated? And for a long time, I think I just couldn't quite explain why they have these, stereotypical movements, I suppose. And basal ganglia makes a little bit more sense.
No, it's at least a connection in your
There's something
thoughts.
there. Yeah.
Yeah.
It's good to put it together.
Yeah.
So I guess, Magnus, from here, like we sort of touched on it a little bit already, but I guess in terms of how we can actually use these neuroimaging results, how would you like to see this implemented into clinical practice and to improve the way that we provide treatments?
Firstly, I think this is a first study of the quantitative, the more qualitative findings of neuroimaging and how they are related to different impairments.
Yeah.
It's really an opening for more studies to be done to better understand how the connection is. But I think we should talk about and be aware of that autism and ADHD are common, actually, regardless of what you find, because some sort of disturbance of the brain function increases the risk. But the more specific help is when you have specific lesions like the middle cerebral artery infarction. Then you should be really aware of attention problems and that you had to deal with those early on. Otherwise, it was common in all findings. And actually, when we divided the lesions, if they were bilateral or unilateral, we found that autism and ADHD were equally common, regardless if the lesion was bilateral or unilateral. But that was contrary to other impairments, because the motor symptoms may they are milder if you just have unilateral lesion, because then you might have the ipsilateral connection left, and you could have a better motor function. But here there is something else affecting. But I think it's more autism and ADHD. In my mind, they are higher cognitive functions and may easier be affected no matter where the lesion appears.
Yeah, it's a really good point. And I think, everything you've described to us today speaks to building as detailed a picture as you can of the children that you're working with, so that you can really, make the work that you're doing as effective as possible.
Yeah, that's right. What you don't want is to, send kids to school without, giving them some of the supports that they might need to support their education. We know that early education is so important, but if they have ADHD and we kind of already know that they're, born term and it's a middle cerebral artery infarction, well, hopefully we can put some strategies in place earlier on, or get a team to assess a child who's preterm for ASD, so that they might have the right support packages in place and, thinking that's early intervention really, isn't it? Yeah.
We have those recommendations in Sweden, at least, that all children with cerebral palsy should be assessed before school starting age, and in some way screen for if you should broaden the assessment for autism and ADHD as well. Because, as you say, the early school age is important for learning, for self-confidence in learning.
So much,
so it's very important to have a good start at school, I think.
Absolutely. So Magnus, we know that you're an incredibly busy clinician. You managed to conduct this amazing PhD on top of all of the clinical work that you do. So I suppose the final question from us is, where to from here? What what do you see as the next steps for this work and your work?
The next step for this work is that we are trying to get the raw data from the MRI done to go deeper in analyzing if we could have some more information about volumes and more specific findings than the more overall description we made here.
Sure.
I am also trying to work with a better screening instrument for autism and ADHD than I used in a previous study. And in that screening, we also got information about mental health,
fabulous,
anxiety, emotional problems.
Right.
And I'm putting that together, analyzing, because that is also more common in children with cerebral palsy, and we should be aware of that as well.
Yeah, of course.
And assess it in an appropriate way.
Yeah. Gosh, that sounds like very exciting work, very much needed again. And I think you keep finding these areas where we just need more information. And you just keep following that pathway, which is really great for children with cerebral palsy and families alike all around the world. So thank you so much for doing this work. But we're not done yet. We're not finished yet. We're going to head into our next segment, and so we can put it all together. And there's a lovely, lovely summary. So as you now all know, we're headed into Tell It to Ed. Ed, as you know, is our producer who doesn't have a background in child health, but he has been listening to everything that we've been saying. He's putting the music on and turning it off and showing me how long we were into it. He's very active through all of this.
He's busy.
He's been busy and he's been listening to this conversation. So Magnus, in about 60 seconds or so, can I get you to summarize your research in this paper to Ed? And Ed, you will have the opportunity for a question. All right, Magnus, take it away.
Cerebral palsy is a condition often associated with impairments. I have been studying autism and ADHD, and neuroimaging findings may give you more information and clues in this area, understanding the background, but also giving information for further treatments and support.
Fabulous. That's a really good summary of pretty much your PhD,
Perfect.
really, of everything you're trying to do.
Wow.
All right, Ed, are you ready for a question?
Oh, I've been listening very intently. And Magnus, where do you think that these kind of results are going to take information and empowerment for families? I'm a relative simpleton when it comes to health, but I kind of understand these are really important things for families to kind of understand. And even people like myself who don't have kids with this kind of impairment or are involved in this kind of industry, what do you think? What do you think of what this information kind of provides to society in general?
Oh, that was a hard question.
Oh, sorry about that.
It was a huge question.
It was.
I don't actually know where to start. Actually, this study, I think, gives some information for applicable for families, but it mostly is a first study that needs to be followed up by other studies to get more information used for specific families. This is more on a group level. It emphasizes the connection between etiology and function.
Yeah, absolutely. And I suppose as a first point, it helps to guide some of the additional assessments that you might want to do, or some of the additional behaviours that you might want to understand of the children that you are working with to try and make your therapy and your interventions as effective as possible.
Yeah, absolutely. And I feel like a lot of times when families might have their early diagnosis, they don't really get given a lot of this sort of information or why is an MRI important? You know, I can see that my child has cerebral palsy. They've been given that diagnosis, you know, they might have GMs or whatever. And then they'll still say, hey, we still want an MRI. Well, actually the reason for that is etiology. And then, and that gives you more information that could really help guide future. So lots of things to think about there. Yeah, that's really cool. Well, Magnus, thank you so much for joining us. We really appreciate your time in a very busy schedule. So we've loved the opportunity talking with you. Thank you for joining us.
Thank you for coming back.
Thank you so much.
No, we've loved it. Remember, to all of our listeners, if you want to access the run sheet notes or the link to the paper, head over to researchworks.net, and there's a CPD form that you can fill out there as well if you want to keep this as a record of your PD. And remember to hit subscribe on your favourite podcast app so you know when we've got new episodes coming your way. But for now, we're going to say goodbye and thank you so much for joining us. So goodbye all. Bye, Magnus.
Bye-bye.
Bye.
Bye.